pleasure to introduce the next keynote, Dr. Trisha Suppes. She's a professor of psychiatry and behavioral sciences at Stanford University and an internationally renowned authority in the field of mood disorders. She's the director of the Exploratory Therapeutics for Mood Disorders lab at Stanford and founder of the Bipolar and Depression Research Program at VA Palo Alto Healthcare System. Her pioneering work has shaped our understanding of mood disorders, especially in long-term treatment strategies and addressing comorbid conditions. Recently, she's launched an exciting new initiative exploring the use of psychedelics to treat mood disorders and PTSD in veterans. And I've had the distinct pleasure of collaborating with Dr. Suppes on some of this work using the neuroimaging. I am delighted to welcome her to the stage, and she'll present on Through the Looking Glass, Psilocybin for Mood Disorder episodes. Join me in welcoming Dr. Suppes.
Good afternoon. Forgive me, I'm a little hoarse getting over a cold, so be sure and let me know if you can't hear me. So we're going to take a little bit of a tour through some past history in psychiatry, and then mostly speak to you about a recent pilot we completed on psilocybin in the Veterans Hospital, which is where I do my clinical research. Okay, here's a few disclosures. And I'll mention the sources of our funding as we go. And I particularly want to appreciate Mr. Eugene Zhang, who made our early work possible and now is making our later work possible as well, and the Cohen Foundation. Okay, this was a lovely cover that the Stanford magazine came up with. Apparently they had a whole editorial about their process, and it fits the subject so well. It was a magazine article about the work we're doing and the collaborative work across Stanford, a number of labs working in this area, including the work Leanne and I are collaborating on. So I'm mostly going to focus on psychedelics today, which is psilocybin. In fact, that's really what I'm going to focus on. I think as anybody who reads the media of any sort, we know there's been a lot of focus on this. And I think particularly because suicide is now a top 10 cause of death in the US, which is a first following COVID. And deaths of despair, as I mentioned here, are becoming more common. So people are looking for hope. I think as we've all learned, trying to see specialists ourselves or friends who are trying to see specialists, access to care is limited and difficult. And so this represented for many people, I think, a different kind of avenue. Okay, so I first actually want to start with history, which is in the 1950s. So the only real mental health treatment before the 1950s that was well recognized in the Western world was ECT, electric shock therapy. And then in the 1950s, we had the beginning of thorazine, antipsychotics, MAO, and tricyclics, which are antidepressants that preceded SRIs, and also lithium. So in the 1950s, it was heralded as the end of mental illness because there were these new drugs and we were going to solve mental illness. That, as we can see, did not happen. And I will suggest later that the new tools we're looking at are going to be useful, but they too will not be the end of mental illness. Okay, so now moving through the 50s to now, basically, there's a whole focus on what I call the era of rapid therapeutics. And that would include TMS, transmagnetic cranial stimulation, which is basically ECT light, in that you don't have a lot of potential downside to a lot of treatment. Also ketamine, and also I think the psychedelics as well. Ketamine was the first time that people woke up, really, in the early 2000s, even though actually ECT had been sitting in front of us for 50 years, which shows equally dramatic changes. You can have somebody with melancholic depression who's basically starving to death, and they'll have 6 treatments of ECT and become a different human being. So we knew before ketamine that actually it was possible, but we hadn't linked it up as a chemical possibility. So ketamine was important to usher in what I view as this era of rapid therapeutics. Okay, I'm just mentioning very briefly what psychedelics are. I'm sure most people know. So they modulate the serotonin system, but they also work in other areas of the brain. And one reason I really enjoy Leanne's work is it's not focused on a single neurotransmitter, but rather looks at how the brain is talking to itself. Physiologically, they're not addictive and not toxic on their own, but there, of course, is a downside. So, for example, if someone were prone to psychosis, the psychedelics can stimulate or cause a psychotic episode. So these are not drugs without risk, and it's very important, I think, to be clear about that as we enter into studying them more. I'm mentioning here that there's been a long time use, as I think we all know, in other cultures of these drugs, thousands of years, actually. And then I think one thing was becoming increasingly clear is the results are context dependent. So set and setting is becoming clearly. So this is super short history, just to bring us all up to speed. I think we know in the 1970s, the majority of psychedelics were early 1970s with Nixon. It was the law against drugs. The psychedelics went underground and really unstudied. And then in '86, the MAPS group began to try to develop a pathway to the FDA and regular legalization, which, as we know, they've floundered on at the moment. So it'll be interesting to see what happens with that. But in the 2000s, there began to be psychedelic assisted studies. So for example, psilocybin is very well tolerated and doesn't have a lot of physiological impact. So some of the very earliest studies were in terminal cancer patients. So that's a very well tolerated drug if you can give a drug to someone who is terminally ill. And I think that was one of the things that brought the drugs into more focus. Powerful impact, not a lot of physiological downside. Through the 2010s, I think you've probably all seen, not to mention Michael Pollack's book, which sort of really took the woo-woo out of psychedelics and really introduced the audience to the possibility of psychedelics being more than something other people did. That was a very profound impact culturally, I think. Okay, so why now? They're still being talked about everywhere. There's lots of papers. There's more review papers on psilocybin than there are research studies by quite a long margin. So the field is stalled, depression, despair is up, and hope really does matter in psychiatry. Sometimes that's really all we can offer people, and it's important, makes a difference. So I think, as we all know, the FDA began to think about these things. Excuse me, in 2017, there was breakthrough status for the MDMA, and then psilocybin for treatment-resistant depression. So breakthrough status actually doesn't mean they skip any steps. It's just a commitment by the FDA that they will move more quickly through the steps. So it's an important recognition, really, by a federal agency that there's not adequate treatments developed in that field. So for MDMA, that there are not adequate treatments developed, so therefore you're getting breakthrough status. It's not a guarantee of approval. And similarly for treatment-resistant depression. And so quickly in our area, we began to develop a laboratory-founded exploratory therapeutics, but the regulatory startup was a little more than anticipated. And then, of course, COVID hit. It was over 3 years. This was actually the first investigator-initiated human clinical trial with DEA Schedule I that was clinically initiated versus a pharma company. And it was the first one in Stanford IRB through 20 years. So then it became a real challenge of how to carry out Schedule I studies at the VA, which was basically an extensive problem-solving experience for me. And we did end up collaborating with Stanford, which has been very helpful. So we actually dose folks at Stanford nearby the VA, and then we do most of the other work at the VA. So still at this point, we're still the only VA carrying out psilocybin treatment studies in depression. There's actually many more MDMA studies than there are psilocybin at the VA, interestingly enough, that are active studies. Psilocybin was studied, though, for example, in the New Haven VA for cluster headaches. And there's actually a whole data background on the use of these substances for headache that's quite interesting. And then I also think I just want to mention Leanne's work. Really, I just wish we could do more of it. I feel like it's so impactful in helping us understand what's going on with these folks. I'm going to show you just a little bit of it. So this is a slide to glance at. Don't even try to read it. These were all the studies, the parts rather, of getting a study going. And in fact, this piece right here, oh, look, it's a round ball. It's a red balloon, not a dot. So RAPSI just delayed us for a year on one study. That's now cleared the way. That was a California legislature issue. So it's impressive what you have to jump through. These are really studies of devotion at some level. Even if you don't believe it, it still requires devotion. So here's just a study schematic. This is for the psilocybin study, where we have one dosing only. And it's just to give you a feeling for the flow. Everyone who was on antidepressants or any drug that could interact with the psilocybin was tapered off because of safety concerns. And that's a non-trivial thing to do. So half of our folks in this pilot were on antidepressants. And even though they're not thinking that it's affecting them, taking them off can actually still unmask some depression. So, one guy told us he had to have his father take his guns away that weekend, and he didn't tell us till later. So that was a little bit of I was very happy. We were staying in very close touch with them the entire time, because the depression is very significant and it can lead to very bad consequences. He was okay. Okay, so to enter into our study, they either had to have failed 4 treatments or had depression without full remission for at least 2 years. All of them made it on the more than 2 years. There's a kind of depression you see in veterans often, where it's like they're never in remission, but they have sort of a low-grade depression called dysthymia. And then they also then get full depression on top of it, but they never have a full remission. So if here's sort of euthymia, they're always down here, and then they get full depression. And that can really go on for years without any type of remission. Okay, so my top priority is always safety, to be honest. That's what I go into any trial with, to be sure that the folks are safe. And we worked pretty closely with the VA and had a surprising number of referrals, to my mind, from the mental health VA practitioners. They appreciated this engagement in an alternative strategy. We had one vet who came from the East Coast who said he'd been looking into these trials for 2 years, all over outside the country and in the country, and felt much more comfortable that the VA, we didn't tell him it was us, that the VA was sponsoring this kind of study. So it was pretty an interesting journey. Okay, so just what is supportive therapy? So the psilocybin treatment is not heavy in psychotherapy. MDMA, which is being considered for PTSD, is very heavy in psychotherapy, 45 hours with 2 therapists. With MDMA, it's more like, an hour and a half, maybe an hour and a half. Then you have the dosing session, and then a couple more hour and a half sessions with only 2 therapists for probably a total of 13 hours. So it's really more supportive. It's not trying to do in-depth psychotherapy. It's trying to help shape the expectations in the sense of what is it you want to get out of this? What happens when you're anxious? So it's an in-depth dial down to try to see what kind of support they'll need during the session. And I should mention, some people didn't talk at all. Some people talked a lot. So it was quite interesting. My job before any of the dosings was really to decrease expectations, because from reading the media, people were expecting this was going to be a miracle. And that's just not true. It's not true. And our data actually even shows that. In any other data you look at, there's a lot of non-response. So a lot of what I did was really like, this isn't going to be a miracle. This is not magic. And so I spent a fair amount of time, which doesn't eliminate expectations, but at least I was trying to bring it into sort of where they would be less disappointed, so to speak. Okay, we had 15 people. About 2 were women, the rest were men. some Asian, African American, and Caucasian. Interestingly, 73 or 3/4 had PTSD. And this is common in the VA. So if you do a depression study, you're going to get a high amount of PTSD. If you do a PTSD study, you're going to get a lot of depression. Very little psychedelic use. Some of the people had never actually even had grass of marijuana of any sort. So that was kind of interesting. I was not expecting that. Again, we tapered about half the folks off medication. This is our dosing room. And thank you to Anna and Max who are sitting over here who help support the lab, and Matt as well. We just did a redosing for somebody. We're now engaged in doing redosing after a year, which I can get into at the end. But so like most dosing rooms, you know, it's fairly neutral. You could make it dark, quite quiet. And this is over on Porter, Stanford campus. So again, I think I mentioned some of this. So we can't do the work for them, but we can help them move towards addressing whatever the work is and what they're hoping to face during a psilocybin session. I should say the dose, which is 25 milligrams, it's synthetic, and the pilot study was funded principally by Compass Pathways. 25 milligrams is enough that people have a full experience, but not enough so that they feel lost, that they feel swept away. And so the metaphor I always used was, it was like the top of the box coming off, and they were going to have a broader perspective, but they were not going to lose a sense of who they were. And my sense is that their experience validated that description. Okay, so I think, as we know, sensory awareness is heightened anxiety definitely can go up during psilocybin, particularly in the early phase when heart rate may go up temporarily, or blood pressure, a nausea, headache. All the side effects were transient. We had no serious or unexpected adverse events during the study. So this is the overview of the study. And this is just a spaghetti graph. I'm going to show you the response curves. If someone restarted, so clinically we followed them for the 12 weeks, or I followed them. And clinically, if I felt there was a need to restart antidepressants, we did so. And so if they restarted, they were then counted as non-responders in our count. So response, you see many people started up here, 30 to 45. So this is the MADRS. 30 to 45 would be viewed as quite severe, significant depression symptoms. And remission, we defined as the standard definition is 10 or under. So if you start at 40 and you have a response, it means you're below 20, but you're still depressed, right? So remission, I think, is a clearer marker. Okay, this is response and remission. Keep in mind, this is an open trial. And my own view is, like every other drug, we're going to end up a third, a third, a third, which is a third nothing, a third something, and a third a more significant response. So I think we should look cautiously at these numbers. It's an open study. This was the primary endpoint, was at 3 weeks. So you see already at 3 weeks, 40% did not meet response. So again, not everybody responds. These are not miracles. They are drugs. They're new drugs, old drugs, but new to our toolbox. And then 12 weeks was the end of that study. We then asked a number of people if they'd like to continue following, and we then followed a subset for 10, the folks who agreed. And what was really interesting about this is again out of 10, the other one was out of 15. And we included people who we were calling non-responders. So we included anybody who was interested. So what's striking about this to me is I was talking to them about every 3 months, as were some of the staff. It's right around 9 months, everybody tapered off. Things were not as good. So there was some degree of a loss of response and remission, whatever the initial was. And that's why we're going, and with the support of Eugene Zhang and also Compass providing meds, that's why we're going through redosing. We're interested to see if they recapture the response or what the impact is of the redosing. Again, I think these numbers are high, and I do want to say something about the remission. Let me go back one. So what I want to say is that I had a nice chat with a Yale colleague of mine, Jerry Sinacora, a while back, and he's been doing mood disorder research as long as I have. So if you look at this kind of remissions, don't even look at the time frame. But what's so surprising is in most antidepressants, the third rule applies, but the third is response, not remission. And so the fact that you're getting anybody into remission who's had very long-term depression, I think the average was 8 to 12 years in these folks. I mean, very significant long period, and that you're getting even close to a third. Again, I think it'll go down in broader use is, I don't understand it. We just looked at each other. We don't understand how this works. I think particularly, why does something like this last so long? I don't have the answers. I think it's going to be an interesting journey to find that out. Okay, so a lot of studies have shown a correlation between the mystical or depth of the psychedelic experience and the response to depression. Our study in our small little sample actually did not show that association. Again, small sample size, hard to know what to make of it. It might have to do with the way I introduced the subject to them, which I didn't talk about ego dissolution, which is an old archaic concept, just putting it out there. And also I didn't talk about oceanic boundlessness. I talked about the top of the box coming off. So I may have set the stage that led to some of this as well. Okay, began the journey as a skeptic. Well, I guess I still am a skeptic, really, in the sense I think these are going to be potentially useful tools, but they're not the end of mental illness. And I think the false hope can be very significant. And I think the risk potential is small, but devastatingly real. And again, I think this is what I've mostly been saying. We don't understand that 1/3. You do want to remember expectancy, which that's why in my own mind, I cut all those numbers in half. When I look at the numbers from the small pilot, I mentally actually cut them in about 50% because it's hard to assess expectancy without a larger and more controlled trial, which there hasn't been time to do yet. So this is coming to a couple nice pictures. So we don't actually know what we're doing, really, but in the initial dose, we seem to be knocking the brain out of its ruts. If you think in depression, how people get into very significant ruminations, kind of like the ski path that just gets deeper and deeper and deeper, and they're unable to pull themselves out of it. It has definitely a passing recognition to OCD. With psilocybin, you actually often seem to knock them out. And I'll show you a picture on that. So there's been a couple different, this is from Robin Card Harris. So this is in the scanner and all it shows in placebo, the brain is just trolling along, but in psilocybin, there's a lot more happening. And then we also, in our collaboration though with Leanne, we did imaging, not on everybody. Some of them couldn't do it in part because they had shrapnel, which is unusual, but we did imaging the day before, the day after, and then about 9 weeks. It was optional, of course, but what we saw was so interesting. This was one of the patients, changed the numbering just for, privacy. But this actually is the person who the Stanford magazine presents, and he was actually quite okay with all that. So he's a 51-year-old guy, former Marine, FBI agent, huge PTSD from his combat duty. And he had been just really living in hell and nothing was helping him. He really was just terrible, felt terrible. So then this is the pre-dosing, and what it's showing is the ski ruts. It's like the rumination. It's all just going back and forth, back and forth. And then what you see is the post-dosing in the red. But then if you subtract, you see that now the connectivity is not like ski ruts going back and forth, that there's some kind of normalization. And again, not everybody responded this well, but he really went into remission and stayed in remission after years of not being in remission. I don't understand it. Not a fun experience. For example, he was talking to soldiers he'd lost under his command. I mean, it was a very painful experience for him in many ways. But he was able to get a forgiveness and a perspective he hadn't had before. And he continued this feeling for months. He's now begun to have more depression, but I think we're going on 16 months now, maybe even a little more. Again, we don't understand why it doesn't work in some and why it does in others. One reason I've been very enthusiastic about working with Leanne as much as funding and subjects allow, because I think we need to have more windows into the brain to have a better understanding, both the initial action and then why it persists. So I'm actually very interested in the people it doesn't work in. It's not just about who responds. If we can understand who doesn't respond, we've actually learned a lot. Okay, so I just want to mention there are psilocybin studies now going on for phase 3. So phase 3 is the FDA stage before approval. So we'll see how that goes. Some of those are being done at Stanford in Chuck DiBattista's lab. MDMA, as you know, has hit a significant road bump. So I don't quite know how that's going to work out. So in the future, we don't really know how these will be used. Will they be in algorithms? Should it be a first treatment? Should it be a fifth treatment? I've done a lot of treatment guidelines, and I think that the potential of rapid acting might suggest you want to put them early and then use more traditional later. But again, we don't know yet. So I think this is a new period. It's an inflection point in the sense that the 1950s were, only now our focus is on rapid acting treatments. Okay, I do want to mention we have 3 posters. One is Dr. Chung from Dr. Williams' lab. She's poster 19, showing more in the brain imaging. And then we have Matt and Max and Matt doing posters on the long-term outcome, both for primary and secondary measures from our pilot studies, and that's poster 4 and 6. So we know psychedelics have been used forever. I just want to keep saying it, public media and expectations has put the wrong expectations for patients. It does work for some. It works amazingly for some, but a larger majority, not so. I'm getting the word. Here's our lab. We have many great collaborators, and then also many people and graduate students and so on helping. Here's our website. With that, I'll stop. Thank you.
Thank you so much for a fantastic presentation. We have time for questions. Oops, take this out.
It's gonna need a mic. Okay.
I think
Do you use anything if somebody's having a bad trip? Like, do you give them an antipsychotic or something like that, where you're kind of assured that they don't go to a dark place?
So the question was, if someone's having a bad trip, what would you do? So we haven't encountered that, but it's a good question because that's definitely a possibility. So if someone was having a quote bad trip, unless they were getting delusional, I don't think I would go for the antipsychotic. So we had lorazepam, which is Ativan, in our safe. We only used it once, but I think it was more for me worrying about the blood pressure of the guy than him. And we didn't have a need. So we screened very carefully against psychotic symptoms. So bipolar 1, for example, would not be, though bipolar 2 you could do, I think, with psilocybin. And there is a recent paper out of Scott Aronson's lab, who's my collaborator on bipolar 2, which showed improvement of depression. But someone who has a schizophrenia history or a close family history, it's unclear about family history and where that plays in. But yes, antipsychotics could be a use. But if I think I was giving someone antipsychotics, I would also be thinking about whether I needed to send them and go with them to the ER. So haven't had that yet. Yeah.
Working with Leanne, did you look at the different subtypes of depression and fMRI scan to see if the people that were successful with psilocybin had a certain subtype?
That's your question. Yes, I hope so.
Sorry.
do you want me to answer?
Yeah, sure.
I'm answering on as a collaborator. So we didn't prospectively look at subtypes. We retrospectively looked, and the result that Trisha was showing was the default mode. So we see this overconnectivity. That's one of the most consistent findings in the 15, but there are 2 other profiles that we want to explore more.
Yes. My hope would be that possibly biotypes could give us a clue on who's more likely to respond than who isn't. That's why I'm crossing my fingers on that. In the back. Can you use the mic?
One of the things that people, I think, hallucinogens have reported are flashbacks in their cases. And as a child of the 60s, I know that. But so have people with PTSD. And that's one of the signs of PTSD. Is there something about the flashback experience that might explain the long remission rates that you're seeing? Are they having flashbacks of their experience on psilocybin?
Yeah, interesting question. So I don't think they're having flashbacks. I don't know that we've queried them, but my impression is they haven't. And as you noted, about 3/4 of the folks had PTSD. So I would say half of that 3/4 actually had substantial improvement in their PTSD, and the other half no change. So their depression was improved without the PTSD being improved. So like anxiety, they can run closely, but they don't always separate in the same way. So it's not a guarantee. There's studies now beginning with psilocybin and PTSD with the focus. And again, if you're in veterans, certainly, and in general population, that means there'll be a lot of depression as well. Yeah. I can't hear you. You got to turn on the mic.
Is that the VA hospital in Menlo Park conducted LSD trials in the 1960s. LSD was legal in California until 1965. You may want to talk to people who were conducting those trials, as well as doctors who worked in the Haight-Ashbury Clinic, on how to deal with bad trips. Usually it was verbal supportive therapy, but you will probably learn a lot from those people who participated. I was a placebo, so I don't take it.
No, thank you for the thought, though. That's appreciated. Yeah, it's an interesting field to be dipping my toes in, for sure. And in the back, I think we're maybe one more question after this.
Okay, I'll be really loud.
Okay,
Hey, now that you're in the psilocybin area. and this-
got to allow louder.
Louder? Okay, is that better? Okay. Now that you're in this field, third time's the charm. Now that you're in this field of psilocybin work, for future trials, if you could, how would you design them inherently different than the FDA trials that you're seeing out there? Would there be any major changes?
I don't think I'd want to compare a randomized controlled trial to an FDA trial.
Or sorry, a randomized control trial, just
Yeah,
the other
yeah.
trials that you're seeing with psilocybin. I'm
Right. Well,
just
the randomized,
curious.
the trials, the FDA, they cost about $50 million each, and they're a particular purpose. So you cannot vary from the box of whatever it is. So yeah, designing a randomized controlled trial here, and I've talked about this with collaborators as well. I think you'd want to have an active placebo, and you'd want to have masking, and you'd want to check later to see what people thought they were getting. I think there's a lot that could be done. And I'm in active conversations with people who are putting in for DoD grants, Josh Woolley and also Boris Heffitz here at Stanford. So I do think there's a lot. I think there's a future in that. And it's very important that we understand the role of expectancy. Thank you. I think we're good. Thank you so much.
Thank you. Okay, great presentation. There will be a chance for ongoing discussion in our panel session, which will be in a few minutes. We'll have a brief break